I again invite Dr. Piya Ballani to speak on hyperprolactinemia.
So the next differential diagnosis that we're going to talk about today is hyperprolactinemia. Prolactin, like we all know, is an important hormone secreted by the pituitary. It plays a pivotal role in reproductive functions. But hyperprolactinemia makes for an extremely important differential diagnosis of PCOS. One, because its symptomatology to PCOS is extremely, there are a lot of overlapping features. And more than that, PCOS in itself, you'll find a lot of polycystic ovary syndrome women also having mildly elevated degrees of prolactin. Now, whether this is due to some common background, whether this is due to the hyperestrogenism of PCOS, where the estrogen is stimulating the lactotrophs to result in prolactin secretion, whether there is some common attenuation of the dopaminergic pathway in PCOS, which then results in prolactin secretion as well, all of that needs to be understood. But the question is that when I have a PCOS woman also who's in front of me with mildly elevated prolactin levels, it's not only important to rule it out as a differential, but also to understand that if the prolactin is high, what do I need to do with it? Because if it's a little high, do I need to treat it with cabergoline, with dopaminergic agonists, like we all often tend to do? Is it something that is not deserving of therapy at all? Or is it something that we need to refer out to a surgeon maybe for something that is beyond what just might be a mildly elevated degree of prolactin? So like we all know, PCOS and hyperprolactinemia have a lot of common symptomatology. Primarily speaking, we talk about menstrual irregularities and infertility. After PCOS, hyperprolactinemia turns out to be the single commonest cause of menstrual irregularities in this age of women with those kind of symptoms. Now, as we all know, prolactin is a monomer, a single polypeptide, which contains 199 amino acids with a molecular weight of 22,000. This molecule was first described in 1970. It also has other forms. Basically, the little prolactin is the one which is the immunoactive form, the one that is causing the reproductive issues. This is the monomer of 23,000 Daltons. The two other glycosylated forms are the big PRL. This has a molecular weight of 50,000. These are the dimeric and trimeric forms, and the big PRL. And the reason I'm bringing this up is because we are often faced with the conundrum of macroprolactinemia as an issue which we again don't know what to do with. But what is macroprolactin? It is big prolactin, which is basically a polymeric form of prolactin, where you have multiple molecules of prolactin with an IgG protein coupled covalently to form this big product. Now, what are the normal values? This is something that I don't need to get into. All of you all are dealing with this day in and day out. But what is very important is to understand the regulation of prolactin secretion, because if I may juggle all our memories that we've learned in medical school, this is really where the crux of the problem lies, and this is what will help us differentiate between physiological and pathological forms of hyperprolactinemia. So basically, prolactin, like we know, is secreted from the lactotrophs in a pulsatile form from the pituitary gland. It is under the dual regulation of two hypothalamic products, one of which, of course, is TRH. This is not working. Okay. It won't work on, okay, sorry about that. So basically, TRH, like we know, which is thyrotropin releasing hormone, is a hypothalamic hormone. This acts in a stimulatory fashion on prolactin. But more important than TRH is the neurotransmitter dopamine, and dopamine is the predominant signal which acts in a tonic inhibitory fashion to suppress the secretion of prolactin. Both of these substances, the TRH and dopamine, come down by the hypophyseal pituitary portal circulation through the hypophyseal stalk to finally result in secretion of prolactin. Now over here, prolactin also, so it's basically the balance between the dopamine and the TRH which is finally going to determine what is the level of prolactin secretion that happens. Estrogen is the other hormone which acts directly on the lactotrophs, due to which prolactin secretion can also increase. And finally, prolactin is metabolized by the liver, and it is cleared renally as well, and that renal clearance itself is also going to determine the final level of prolactin. The action, like we all know, prolactin acts basically on the breast. It increases breast size during pregnancy, induces lactation in the puerperium, and also has a negative action on FSH, LH, it causes a suppression of the gonadotropin levels as well. A lot of physiologic conditions that we must be aware of: sleep, feeding, exercise, coitus, the menstrual cycle, pregnancy and puerperium, all of them, nursing of course, all of them cause prolactin levels to go high. So if you have a PCOS woman, if they have told you that, if we find that the level is elevated the first time, a second sample should be collected when she is fasting and non-stressed. But coming then to the other main causes also of hyperprolactinemia, like we said earlier, one of the physiological causes, of course, is pregnancy, which causes increased estrogen, hence increases prolactin. All neurogenic stimuli like chest wall injury, breast stimulation, breastfeeding will, via the ANS, suppress dopamine, and so when you inhibit the inhibitor, you're going to get an increased prolactin secretion again. And if prolactin elimination is inadequate through decreased renal and hepatic clearance, prolactin again will be increased. Anything that increases TRH, it's going to increase prolactin. So primary hypothyroidism, which by its feedback mechanism is going to result in increased prolactin. Also in primary hypothyroidism, for that matter, there's a decreased clearance of prolactin that happens, due to which, again, prolactin secretion can increase. And for that matter, if you check women with primary hypothyroidism, you do an MRI, you'll often find these women sitting with an enlarged or diffusely enlarged pituitary gland. And with the onset of thyroid treatment, the swelling also comes down. A lot of medications, like we should all be aware of, cause high levels of prolactin. So this is your list: the phenothiazines, haloperidol, some antihypertensive, CCBs are commonly used, methyl dopa, you all use it as well. Psychotropic agents, some of the biggest culprits, anti-ulcer agents which are being used left, right, and center, and opiates, all of these commonly cause levels of prolactin very often between the 25 to 100 range, with some of the drugs like phenothiazines, etc., even up to 250. Finally, macroprolactinemia. This is what I was alluding to earlier. Macroprolactinemia is when patients have a high quantity of the big prolactin, which normally is present in the blood in around levels of around 5%. When this becomes over 60%, you might get a patient who's completely asymptomatic. Normal menstrual function, no galactoria, nothing at all, but when you check the blood, prolactin levels are high. So why is this happening? It's because this polymeric form of prolactin is being picked up by the immunoassay, but it is unable to react at the site of the prolactin receptor. So there are no symptoms, but when you check levels, the levels are high. If you have suspicion of macroprolactinemia in a patient, the best thing would be to subject it to PEG precipitation and make sure that this is macroprolactin, because if in case the cause of the hyperprolactinemia is macroprolactinemia, indeed, this does not warrant treatment. Also, macroprolactinemia, of course, I should say that should not be confused with macroprolactinoma, which is basically a tumor measuring more than 10 millimeters in size. So these two entities are completely different. And finally, some of the commonest causes that as an endocrinologist I deal with is basically pituitary tumors. 25 to 30% of cases of high prolactin are due to pituitary tumors. The commonest, of course, being adenomas, which will result in levels going high. But 1/3 of these adenomas also are not hypersecretory of prolactin. So why does prolactin go high? Because when these macroprolactinomas, these large tumors, if they have a suprasellar extension, they will cause compression of the hypothalamic, the stalk, therefore resulting in what we call the stalk effect. In this kind of patient, she will present basically with headaches, with visual disturbances, nausea, vomiting, etc. But this is basically a non-functioning pituitary adenoma with a slightly high prolactin level, which is not corresponding to the size of tumor, but the prolactin level is high due to stalk effect. This is the typical kind of patient that should not get a dopamine agonist. This is the kind of patient where you have to keep your eyes open, because this patient is deserving of surgery, especially if symptoms of stalk compression are already present. Delay should not be happening. And then finally, we have hypophysitis. This is like an autoimmune lymphocytic situation of the pituitary gland, which results in a temporary rise in prolactin, does not again need any treatment. Steroids sometimes are given, but again, in this kind of situation, it self-resolves and does not need to be referred to a surgeon as well. One last kind of situation that we should be aware of is that Prolactin secreting tumors very often coincide with growth hormone secreting tumors as well. So when this kind of patient presents to you, she might have some galactorrhea, which you'll pick up, and some amenorrhea, which of course you'll pick up. Prolactin levels are high, you start off on your medication, but what you have missed are those subtle features of growth hormone excess. Again, this is the kind of patient. Acromegaly, growth hormone secreting tumors, no D2 agonists. These are deserving of surgery. So again, keep your eyes open. If there's any history which is suggestive of growth hormone excess, send the patient over for further evaluation to an endocrinologist, neurosurgeon, take your pick. So basically, the prevalence in the normal population of this situation is around 0.4 to 5%. And let me point out, amenorrhea and galactorrhea, when you have these two symptoms, these two signs in association with each other, the chances of this being a case of elevated prolactin goes up to 70%. In polycystic ovaries, basically, prolactin has been found to be elevated in 19 to 50% of women with PCOS. Now, the precise link, like I mentioned earlier, is difficult to know. There are schools of thought saying that there is some common antecedent cause which is resulting them to coexist so often. Maybe the hyperestrogenic levels that are occurring in PCO, maybe that, maybe the dopaminergic activity is maybe a little lesser in PCOS women, all of which might be causing the slightly elevated level. And as the levels of prolactin increase, you might find you have symptoms which are increasing from a decreased libido, short luteal phase in the early 31 to 50 range, oligomenorrhea 50 to 70, and then the patients become hypogonadal with galactorrhea, amenorrhea as the levels go higher. Body weight is not that common. It's generally when they're associated with other pituitary tumors, maybe the cortisol secreting types. Osteopenia, because of the hypogonadism associated with the hypoestrogenism of hyperprolactinemia, that is when you might get osteopenia as well. And of course, if there are symptoms of tumor mass, always keep your antennae alert on that front as well. So now, what are its mechanisms of hyperprolactinemia on the reproductive dysfunction? So like we spoke earlier, there's inhibition of GnRH secretion. The decreased FSH-LH will then interfere with its action on the ovary. There's therefore decreased estrogen, which will result in an interference with the estrogen positive feedback. There's an inhibition of an FSH-directed ovarian aromatase, preventing therefore the conversion of testosterone into estrogen, and inhibition of the LH-mediated progesterone synthesis, all of which will also result in impaired follicular development. I'm not getting into the men part over here. The diagnostic approach, just a little bit of a reminder that if you have somebody with more unilateral, single duct, bloody or serosanguinous discharge associated with the breast mass, this patient needs to be referred to a surgeon, get a mammo, sono, all of that done. Galactorrhea typically is defined as, in this kind of situation, as bilateral, multiductal, milky. It can be a little differing in color. Check a prolactin is your next step. Now, if the patient has galactorrhea with an elevated prolactin, your next step is to, of course, first rule out physiological or secondary causes. 90% of cases of hyperprolactinemia, you can find the reason on history alone. So take a good history, make sure there are no secondary causes, because these patients, again, should not be getting any therapy. So if the patient tells you about recent breast or nipple manipulation, medications, again, a very, very important history to rule out. And if in case it is truly what you suspect is a medication-related issue, stop the medication for 3 days, recheck the levels again, and make sure that the prolactin levels come down. If you can substitute if the medication can't be stopped, substitute it with another that doesn't raise prolactin. And if in case you can't stop the medication at all, the recommendation is that the levels are high, actually rule out a pituitary mass with the help of a Seller MRI. Of course, a patient with this kind of, make sure you don't miss pregnancy. I might, I know you won't. Kidney liver disease, hypothyroidism, PCOS, all of these are the differentials for hyperprolactinemia at the start. Now, an important objective of treatment is, of course, to maintain gonadal function, fertility, prevent osteoporosis, and of course, if a tumor is present, we need to look at other things, correction of visual neurological abnormalities, removing the mass, maintaining pituitary function, preventing further pituitary or hypothalamic disease as well. So this is, of course, in a nutshell. This becomes much, much more detailed. I didn't think it was that necessary to go into that much detail today here. But high prolactin levels, first, rule out macroprolactinemia. It does not need treatment. And I hope everybody is clear about what that is. Rule out secondary causes. I'm going to the far end. If in case it is hypothyroidism, you treat with thyroid hormone. Again, so make sure you ruled out all secondary causes as per what we suggested in the workup before you call it pathological hyperprolactinemia. If it is indeed so, an MRI is what's done next. If the patient's pituitary is normal, but the patient is symptomatic, you could consider therapy with your D2 agonist. If it's a micro lesion less than 10 millimeters, again, medical treatment. And a macro lesion, again, one could start with medical treatment if it is not compressive, but if it fails, you go on to surgery as well. Now, this is another important thing that I thought I should bring to your attention. The hook effect is another, let's say, a googly in the whole diagnosis of hyperprolactinemia. This is a situation where you might have a very, very large tumor, but the level of prolactin is not that high. So the question becomes, is this a large prolactinoma that is secreting smaller quantities of prolactin? And remember, prolactin is often, the levels of prolactin are often very correlated with the tumor size. So if you have a large tumor with not such a high prolactin level, again, you need to be aware about what's going on. So a large prolactinoma versus is it a non-functioning pituitary adenoma causing a stalk effect? In this kind of situation, what might be happening is what we call the hook effect. Basically, what is that? That if in a large prolactinoma, the prolactin levels are actually very, very high, the prolactin molecules will saturate what we call the captured antibodies and the detection antibodies. The way the immunoassay works is that the capture antibodies and the detection antibodies form a sandwich with the prolactin molecules. If this sandwich is formed, it'll get detected. But sometimes if the prolactin levels are so high that all of these sites get saturated, you might actually get lower prolactin levels than is actually the case. So in this kind of situation, one needs to dilute the sample with a 1:1000 dilution and recheck prolactin levels. The drugs that are used are something that you all are already very familiar with. Bromocriptine has a long track record. Doses 1.25, 2.5. Vaginal route has been used. If the oral route, there have been difficulties with that. Cabergoline now has become the agent of choice. Very, very small side effect profile. Doses generally started at 0.25 milligrams twice a week. But be aware that with cabergoline, other than those routine side effects that we talk about, the nausea and the giddiness, there have been reports about patients developing manic behavior. Manic behavior to the extent of sexual, gambling, shopping, spending money, having affairs. It has actually been known that patients on cabergoline, especially on very high doses, develop sometimes psychotic behavior. There have been articles about how homes have broken up when women on these kind of medications, women or men for that matter, have developed altered behaviors resulting in such far-reaching consequences. And as a result of which I say that this is not a medication that we need to do one for all and all for one. Think carefully before you hand out this medication as well. In resistant cases, pergolide has been used as well. Well, generally, when we can start tapering, of course, if the levels are coming down, but in general, women who've had levels that have been suppressed for a period of time, no growth seen on MRI, one can basically taper off for women with a microadenoma roughly after 2 years. The return to regular menses is very, very fast, as is seen in the graph. In 1 month, 2 months, 10 months, progressively there's a return to normal menstrual function. Pituitary surgery, this is just so that you all are aware if there's dopamine agonist resistance or intolerance. Again, if there are persistent visual field defects, neurological signs, cystic macroprolactinomas, or tumor enlargement symptomatic during pregnancy, all of these need to be referred immediately. And lastly, during pregnancy, what is the recommendation? One can, in microadenomas, discontinue the dopamine agonist, basically because the growth chances are small. You can continue dopaminergic therapy throughout pregnancy if you have invasive tumor or there's symptomatic growth. Of course, prolactin levels useless. MRIs should not be done in pregnancy, so this is what you monitor, maybe visual fields alone. Surgical resection if you have resistant or intolerance to the drugs. So this is my concluding message. Keep your eyes and ears open. Not all hyperprolactinemia is due to a prolactinoma. and one should recognize and be able to deal with the differentials on an as-needed basis. Thank you very much.